Oh, we don't have to do the camera. Okay, perfect. All right. So thanks for coming. We're going to be talking today about pulmonary manifestations of rheumatoid arthritis. My name is Zach Bauer, in case you don't know me. And thanks to Dr. Abusef who helped me out with this talk. So this is what we're planning on going through today, kind of what is rheumatoid arthritis, briefly touch on some of the diagnostic criteria of it, what it typically looks like, and then we'll jump into the stuff we care about more is the pulmonary manifestations. So rheumatoid arthritis is a chronic systemic autoimmune disease of unknown etiology. Typically, we'll talk about it has to be at least 6 weeks in duration. And this is a chronic erosive disease. So eventually we'll end up destroying your cartilage or your bones, especially if it's left untreated for long periods of time. One thing that's important to know is it's typically symmetric involvement of your joints. So it's like you'll see in this picture of the hands, the ulnar deviation, the MCPs all look like they're all involved. And typically, people between 30 and 50 will be affected, but it can be as late onset as 65 years old. So the most common symptoms that these people will have is joint pain, swelling, and stiffness. You know, it is a rheumatologic disease, so that makes sense. And it affects typically the hand joints first, or not first, but most commonly. So the metacarpal phalangeal joints, the proximal interphalangeal joints, or the metatarsal phalangeal joints. But you can see it in the elbows, wrists, shoulders, all throughout. And these people typically have morning stiffness. Classically, talk about lasting more than an hour. That goes away throughout the day. And as they keep moving, which is what's known as the gelling phenomenon, that as they get moving more and more, their pain actually lessens. Which is not what you typically would see in like osteoarthritis, right? Some important mimics to know about is polymyalgia rheumatica can actually sound almost exactly like rheumatoid arthritis, but not involve the hands. And this can sometimes be the only thing that you see before they eventually get diagnosed with rheumatoid arthritis. So they might have aching shoulder pain, joint stiffness in the morning that lasts for a long period of time. And it sounds just like polymyalgia rheumatica, but you could test them and they'd have positive antibodies for rheumatoid arthritis, or later in a couple of years, develop positive antibodies and a more full-on picture of rheumatoid arthritis. Palindromic rheumatism is almost like an intermittent episodes of rheumatoid arthritis that can actually be the manifestation of multiple different diseases. But if someone comes in with bilateral, especially hand, joint pain, swelling, stiffness that lasts a couple weeks, then completely resolves, and this happens intermittently over time, it could be a sign that they will go on to develop rheumatoid arthritis. So this is the diagnostic criteria that's currently being used according to the ACR and the European rheumatologic societies as well. These are kind of loosely followed by rheumatologists. I think that they adhere to this for the most part, but these are not hard and fast rules that they have to be present. The one thing that is consistent is they have to have synovitis of at least one joint. So not just joint pain, not just joint swelling, but true, inflammation in that joint. So typically you'll feel like bogginess in their joints, or maybe see erythema, those type of things. So lots of joints are typically involved, and the more joints, usually more points you get. One thing I want to point out is with the serology here, is what they define as low positive and high positive is this cutoff of 3 times the upper limit of normal. So if you have a rheumatoid factor or anti-CCP that's higher than 3 times the upper limit of normal, that's much more predictive, especially in the right clinical setting, that they have rheumatoid arthritis. So that's considered high positive. Whereas low positive is it's higher than the reference lab, but it's not higher than 3 times the upper limit of normal. So if your normal lab is 52 IUs and you have 53, then technically that's a low positive. So, and both of the serology factors that we talk about are more specific than they are sensitive. And so you should use them in the right patient presentations, but generally anti-CCP is thought to be much more specific than RF is. And know that this criteria has nothing to do with anything like rheumatoid nodules, ILD, X-ray deformities, all those things that can happen with rheumatoid arthritis that are not part of this criteria. So it's not a perfect criteria. If you're thinking about rheumatoid arthritis, you should think about some other things. You know, if it's not very long and it resolves on its own, maybe it was a virus that caused their joint pains. There's lots of other inflammatory arthropathies that all can cause joint pain that also have pulmonary manifestations. So we might be thinking about these as well, like lupus, mixed connective tissue disease, sarcoidosis can have some joints, joint involvement that can mimic rheumatoid arthritis, and hand involvement as well. And I found out that immune checkpoint inhibitors can also mimic RA. So it's just another thing that they can do that can get confusing for when you're looking at pulmonary manifestations as well. There's this thing called Jacques arthropathy, which I think is very interesting. So I included a video of it. If you're like squeamish to joint stuff, I would look away because it's kind of weird. But this is a deformity that's caused by joint laxity, not actual deformities, not actual erosion of the joints themselves. So in theory, they should get better. And I was taught in med school that that's a sign of lupus. And now I found out that's actually could be lupus, it could be sarcoid, it could be mixed connective tissue disease, or sometimes even rheumatoid arthritis can present like that. So if you see that, you know, you should have some concern that they have autoimmune joint disease, and probably a rheumatologist should see them at some point. All right, so getting into the stuff we care about a little bit more, pulmonary manifestations. There's a whole laundry list of diseases associated with RA, and most of the symptoms are very nonspecific. So cough, pleuritic chest pain, dyspnea, you know, most of our clinic patients would present with one of these symptoms or more. But rarely you can even see stridor, hemoptysis. And as a general rule of thumb, if you have pulmonary manifestations, you're more likely to be a man, and you're more likely to have rheumatoid arthritis, joint disease for a long period of time before pulmonary. Not always true, but it can be true. All right, so we're here in a tertiary care center. So let's say that Hashmi decided that he's going to open up a special clinic that's purely just rheumatoid arthritis and pulmonary complaints. So this is his clinic. We're going to run through some patients today, okay? You have a busy morning, so we'll get started. And that's just a funny clip. All right, so this is your first patient. It's a 65-year-old guy. He's got a chronic cough and dyspnea. He's been a smoker for 20 years. And he comes to your clinic with these symptoms, and you got some spirometry and a diffusion capacity, and his FVC is mildly reduced, and his DLCO is reduced as well. And you decided, or maybe it happened already, he has a high-res CT. So what does this CT remind you of? Yeah, exactly. So this looks a lot like UIP. You see honeycombing, you see traction bronchiectasis, reticular changes, and at least from this cut, you're seeing an absence of other features to suggest some other diagnosis. And if this gentleman had absolutely no review of systems or drug history to suggest otherwise, you'd call him IPF. But if he had a long-standing history of chronic joint pain and swelling, and you sent off a RF and it was greater than 3 times upper limit normal, you could say that this is RA-ILD associated. Okay, so we're going to make a small change. What if actually this was a CT scan? Would this fit with this rheumatoid arthritis? Right, and you can see there's ground glass and more getting to almost consolidations here. There's less fibrosis for sure. Maybe you can say there's some traction bronchiectasis here, but it's not really the predominant feature. And if you oh, sorry, my mouse is on the wrong side. Okay, and if you track the pleural around here, you can say there's like a relatively spare subpleural sparing right there. So you call this probably like a cellular NSIP. And can you see that in RA? The answer is yes. You can see NSIP as well in RA. Okay, so last CT scan for now is this. And is this something you can see in rheumatoid arthritis, and what is it, if you know? And I gave you a little hint for, yeah, it's a toll bridge or whatever. And that's an toll sign, or the reverse halo sign, that you get a rim of more consolidation with, it's supposed to be generally ground glass, but this almost looks normalish parenchyma. This is not from RA in this specific picture, but it's an organizing pneumonia. So RA-ILD, this is the most common manifestation pulmonary wise of rheumatoid arthritis, so it's important. We're going to spend some time on this. This is a lot more prevalent than I thought it could be. So apparently up to 60% of patients with rheumatoid arthritis have some mild fibrosis on imaging of their lungs. And if you took all of the people with rheumatoid arthritis and put them through spirometry and diffusion, that up to 40% of them would have a reduction in their DLCO. But if you took that further and said, do you have symptoms that we can attribute to it, then it's only about 10% of people. And these are more likely, again, to be men, and again, more likely to have chronic long-standing joint disease. Okay. And then the people with overt fibrosis, it's much lower. So 1 to 5%, but still this is pretty significant to have 60% of the people with RA to have some sort of pulmonary fibrosis. The most common idiopathic interstitial pneumonia pattern that this mimics is UIP, but you can really see almost any of them. So some of the studies will say anywhere between 5 to 65% of these people have UIP, and then 5 to 50% have NSIP. So you can see that's almost similar. This specific study listed 37 and 30% of people UIP and NSIP. Whereas organizing pneumonia was closer to 8%. And then very rarely you can see LIP, DIP, or progressive massive fibrosis or Kaplan syndrome. But really it can mimic anything. And this is often confounded by the fact that a lot of people with rheumatoid arthritis associated ILD smoke as well. So there's a lot of confounding factors. I found some studies that are interesting looking at prognosis related to RA-ILD. This was a 2019 ERS article, and they subdivided people based off their CT patterns and distribution of their disease. So they use the same white paper of the Fleischner criteria definitions of definite UIP, probable UIP. But then I went further to say, is this in the typical distribution? So IPF should be more basilar, predominant, subpleural. If it's not in a typical distribution, maybe it's more anterior upper lobe. And it divided these people into 5 different groups. And they followed them for 5 years. So, and this is kind of busy, but I want to draw your attention to this top one up here. So group 1 is this, you could tell me this is IPF and I believe you. Group 2 is it looks pretty much like IPF, but it's in a different distribution. Group 3 and 4 are both the probable UIP, but depending on the distribution. In group 5 is it doesn't look anything like UIP. So you can see here that the definite UIPs have a worse cumulative survival as compared to probable UIPs and inconsistent with UIPs over the follow-up. And when you group them purely disregarding location and just on definite or probable UIP and compare it to IPF, that's what this chart is doing here. IPF is this black line here. It's pretty poor, but the definite UIP tracks that almost identically for the first 3 years and then kind of levels off, which I think is kind of interesting. But you can see that, the prognosis, at least in the short term, is IPF, so poor prognosis. And the further away you get from definite UIP, the better the prognosis is. And the biggest things that they thought were predictive from this study is sex. So men had a worse prognosis. Honeycombing had a much worse prognosis. And this term I'd never heard of before, but it's kind of like this thing that's evolving in the literature, is something called vessel-related structures. They took a computer program. Apparently CALIPER stands for Computer Aided Lung Informatics with Pathology Evaluation and Rating Software. Someone thought, if I can take a CT scan and define the amount of fibrosis, I can, do prognosis or something like that. And they thought, I need to subtract all these vessels because that's not lung. And then they, what does this look for risk ratios? And they actually found that the vessel-related fibrosis, so vessel-related structures, was the highest predictive thing for mortality. So that's been used in IPF literature to predict mortality. And similarly here, they use it as 4.4% was what we used before. And you can see here in this graph, again, the more vessel-related structures, irregardless of definite, probable, doesn't look like UIP or location, is a worse prognosis. So this is something that's kind of interesting that I found out about. But there's also some studies looking at just purely vessel-related structures and diagnosis of IPF, so that might come out later that you might hear about. Another study in ERS, this guy Solomon has done a lot of research in RA-ILD, pretty consistent with what the last study showed. UIP on the graph up on top in the red, much worse than NSIP. And again, if they've ever smoked, if they have UIP on the high res, those are bad predictors of outcomes. Additionally, if their FVC or DL drop by 10% at any point during their time, so not at the initial, it's not reduced by 10, but over time drops by 10, That's another poor prognosis indicator. So treatment is kind of, this talk isn't about ILD, but I'll try my best to give some summaries here. So you're going to look at the drugs that they're on, because oftentimes the drugs that they're on for their RA can be associated with lung disease as well. If they just have mild fibrosis and minimal clinical symptoms, you can monitor these people over time with, PFTs, high-res CTs every now and then. If there is a significant amount of ground glass, and especially if they have a lot of extra thoracic disease, you can consider doing some steroids, and then based off that response, whether or not they would need a DMARD or not. The literature for steroid sparing agents isn't great. Most of them are case studies or retrospectives. The mycophenolate data was actually used like grossly in CTD-ILD, not RA specifically, but about 18 people, not percent, in this one case study had RA-ILD, and they had a modest improvement in their FVC and DL and a reduction in the steroid dose. But you got to know that that doesn't treat their joint disease. So you're going to have to use something else for their joint disease, because this is a chronic erosive joint disease. So that kind of makes that fall out of favor. Methotrexate, we'll talk a little bit about in a bit. Rituximab, tocilizumab, and abatacept have very similar data. You'll find that in general, about 50% of people have their lung function stabilized, about 25% of people have improvement in their lung function, and about 25% of people still have worsening despite these agents. So there's no like gold standard, this is the best medicine for it. There's some data about antifibrotics in RA-ILD. So nintedanib was used in the greater study of progressive fibrosis ILD, and pirfenidone was used specifically in one abstract just purely for RA-ILD, which I thought was very interesting, because there's no enrollment criteria other than you have RA-ILD, not you're declining over time, not you're failing therapy, like there was in the progressive fibrosis ILD study with nintedanib. Just if you have RA-ILD, we're giving you pirfenidone. And that showed, similar to the nintedanib progressive fibrosing ILD study, that it did slow lung function decline. So this kind of wasn't the best study because it started in 2019 enrollment, and then COVID happened. So it didn't fully reach the amount of people that it needed to power the study. But you could see in the future that potentially that we might be getting antifibrotics with everyone with RA-ILD, regardless of symptoms or PFTs, which would be very interesting. So methotrexate, we've talked about a lot previously about causing lung fibrosis. So can we use it in RA, especially RA-ILD is something that I think is interesting. This one prospective trial found almost 3,000 patients that as soon as they were diagnosed with rheumatoid arthritis, stratified them into how long until they get RA-ILD, and were they ever exposed to methotrexate. So just a single dose, they were considered exposed or never exposed. And this graph here, survival, is time until ILD, so not death. And about 93 cases of these almost 3,000, which is close to that 5% what we talked about previously, what you'd expect, had RA-ILD. And if you were ever exposed to methotrexate, so even just one single dose, your odds ratio of getting ILD was cut in half. So that kind of brings to question, did they get fibrosis from the methotrexate, or was that protective and their rheumatoid arthritis would have progressed till fibrosis anyway? It's not a clear answer, because methotrexate can cause an acute non-cardiogenic pulmonary edema, almost like HP. And you really got to look at the patient themselves, how much fibrosis they have, what's the reserve lung function, and when did their fibrosis come up. If it's right after you gave them methotrexate and they started to worsen, then you can't really justify giving it to them more. But it needs to be a patient by patient decision, and it can't just be a blanket statement. They have RA-ILD, they can't be on methotrexate, and it might actually be protective for some people. Regarding organizing pneumonia, this isn't really a talk about organizing pneumonia. So there's this paper that, if you're interested in it, and that was recently published in Chest, that really goes through in depth about everything about organizing pneumonia. But generally, these respond favorably to glucocorticoids. You need to make sure that it's not just purely a connective tissue disease cause, and then that there are chances it could be infectious or drug induced. But this is pretty typical for what you would do for the rest of organized pneumonia. steroid with a max of 60 per day, slow taper over time, and reassess once they're on about 10 of pred. All right, so this is kind of a summary slide that we're going to fill this all up with everything that RA can lead to. So first thing, ILD, this is most common. You got to remember this, okay? So Hashmi, you spent a really long time on one patient, okay? So this is your next patient here. So a 55-year-old guy, he's got known rheumatoid arthritis, comes with a chest pain on inspiration. He's also had fevers, dyspnea, and cough, okay? So anyone brave enough to say what they see on the x-ray here? All right, someone say right. That's going to be close enough. So there's kind of almost, there's blunting here for sure. You can almost see like a meniscus here. And if you look on the lateral, it looks like you are seeing that this is kind of the anterior diaphragm dome in here. So there's a pleural effusion here. About 20% of people with rheumatoid arthritis have pleuritic chest pain. And about 5% of those will end up having a pleural effusion. If you did autopsies on everyone with RA, apparently up to 70% of people have some sort of pathologic pleural effusion. And again, this is another one seen years after joint disease onset and more commonly in men. All right, so now we're doing a question about this. So which of the following are false about RA pleural disease? And multiple answers are false, just so you know. Okay, so rheumatoid arthritis can mimic a pneumonic or empyema with low pH, low glucose, and clinical history of fevers and dyspnea. B, RA can present as a pneumothorax through rupture of pleural rheumatoid nodules. C, RA can present as a chylothorax with high triglyceride level due to chronic inflammation. RA can lead to non-expandable lung from chronic inflammation. And E, RA effusions rapidly improve with treatment of RA joint disease. So does any of those stick out that are not true? Okay. And there's at least one other one. I told you that. There's at least two wrong ones. I'll let you know what other one is wrong. I'll tell you it's one other one. So C is wrong. You guys are right. E is also wrong. So RA can definitely mimic an empyema and pneumonic infusion. And to make things more confusing, these people are often immunocompromised if they're on drug therapy, and they have a higher incidence of infections than the normal population. So it's not straightforward and easy. RA patients often have pleural deposits on autopsy. Typically, it's more on the parietal pleural than the visceral pleural, but you can get on both. These can rupture, they can cavitate, they can necrose. You can get even a hemopneumothorax from these as well. See, so it's not, they can get a pseudochylothorax and not a chylothorax from a high cholesterol level from chronic inflammation. So not triglycerides, not chylothorax, pseudochylothorax and cholesterol. And that chronic inflammation can lead to a non-expandable lung. So that's true. And RA effusions do not improve rapidly. They take anywhere from 1 to 36 months after initiating treatment. So mean of 14 months is definitely not quick. All right, so an RA effusion, that's something that is also very important for us to know about. Oftentimes it's on one side, small to moderate size. Oftentimes we'll talk about serous effusions, but if they have a pseudochylothorax from it, it can be milky. If they have a hemopneumothorax, it can be hemorrhagic, right? Glucose will generally be less than 60, and oftentimes it's much lower than that. This is from impaired glucose transit across the membrane. They'll have a low pH, will be exudative, typically a lymphocytic predominant effusion, but it can be neutrophilic or eosinophilic acutely, or if there's blood in the space, the eosinophils will pop up. And the one thing that is kind of more specific to an RA effusion is that if you have a RF factor on it that's higher than your serum, that's pretty much diagnostic of it. This top thing here, I had never heard of these before. This is apparently called a rhagocyte. If anyone ever tells you these multiple inclusion bodies, apparently on joint effusions and pleural effusions, if you saw this, people used to think that this was related to RA. That's actually not true. It's neither sensitive nor specific. So it's more just a pretty weird picture. And the bottom one here, this is something that might actually be important. This is a comet tail macrophage, an elongated macrophage. This is not sensitive at all for RA, but it is specific. So if you were to see this in the pleural effusion, you could say, wow, this is probably related to rheumatoid arthritis. And then I did find one patient that had known RA pleural disease, and this was repeatedly tapped. Glucose for this person was always less than 10. The pH was low. The LDH was always very high. So you could see how if you saw these numbers without looking at the patient, you could easily be tricked into saying that they need a chest tube and they have an empyema or paraneumonic effusion. All right, so pleural disease as well. These are the two most common ones, and you should always know these two. All right, so Hashmi was lucky enough to get a lunch break for his clinic, and now it's afternoon clinic, okay? So you get a middle-aged woman that comes to you. She has known rheumatoid arthritis. She's got dyspnea. She has trouble taking in a deep breath, and she has a hoarse voice. You got Spiro today. All the flows are normal, and the flow volume loop is shown. Does anything stick out to you guys about this? Yeah, exactly. So there's some sort of extrathoracic variable outflow obstruction. And specifically with RA, it can be related to laryngeal disease. So rheumatoid arthritis affects the synovial joints. The cricoarytenoid joint is synovial joints. So these two, where's my mouse at? These two joints here that are sitting there can be easily affected by rheumatoid arthritis. And over time, if this is your normal vocal cords, if those are inflamed, they tend to come more medially and they're not able to fully abduct normally. So you can get a laryngeal obstruction like that, very similar to vocal cord paralysis. This is more easily seen on CT. It's a better study to look for it, but laryngoscopy can be helpful in ruling out other diseases at the same time. And the bottom picture shows that this area is really red and inflamed, and the upper photo is after long-standing disease has already been happened. You can see how deducted everything is, and that's stuck. And eventually this could present as stridor if it was untreated for that long. All right, so your next patient's 62. It's a guy with RA. So you got cough and productive sputum and dyspnea for many weeks. You got Spiro on him, and he's got a reduced FEV1, and the ratio is also reduced. His X-ray was read as normal. He ordered a high res for him, and you can see here significant bronchiectasis, and there's even some tree and bud in the posterior lateral lung bases, more so on the left. Is this something that could be related to his rheumatoid arthritis? You guys have any clue? What was that? No, it's just RA itself has been, and a lot of other connective tissue diseases are associated with bronchiectasis. And you should know this, you only see people with RA, so I'm just joking. This is a very nice picture from Murray and Nadal's. They have a wonderful chapter on bronchiectasis if you want to know more about it, but up to 10% of people with RA can have bronchiectasis. This is very interesting, and it'll pop up again later if you remember. This one small study found that 16% of these people had a single mutation in the CFTR gene in the patients that had bronchiectasis, but on the patients that did not have bronchiectasis but did have RA, none of those people did. And the 16% was higher than the general population of about 3%. So maybe this is related. They tested them all for CF and it was not present. And the distribution should be different. So RA is typically lower lobe predominant, CF is upper lobe predominant. Just kind of interesting thing that probably is not relevant to clinical day-to-day, but your treatment for RA bronchiectasis is very similar to the other non-CF bronchiectasis you're going to do. You'll do chest physio, mucus clearance techniques, you'll watch for pseudomonas isolates, all that type of stuff. One thing that was brought up was to avoid TNF alpha inhibitors, because there's conflicting studies on this. Some will say there's an association with TNF alpha inhibitors worsening ILD and worsening your fibrosis in these type of patients. Other studies will say there's absolutely no difference. You can use them safely, but just something to be aware of. All right, so let's say that this person is the same person, but this is different studies for him, a different X-ray. Still has the spiral that looks very similar. This was his high-res protocol. He got an inspiratory and an expiratory filmed. So you can see there's significant air traffic here. Is this something that can be seen with his RA? Hashmi knows. Yeah, for sure. So I've seen this before. Yes, this is small airways disease related to a connective tissue disease, specifically rheumatoid arthritis. And then a different patient, well, same patient, but slightly different. X-ray is normal. PFTs are actually normal this time. And someone got a high res and it looked like this. So diffuse tree and bud opacities. This is actually a case of follicular bronchiolitis, which is a subtype of small airways disease. And this one little arrow here is pointing to bronchial wall thickening, which is also seen commonly in small airway disease. When I was trying to find what's the difference between follicular bronchiolitis, like this severe, and diffuse panbronchiolitis, there's not a clear answer. So I don't really know. If someone else knows, maybe they can help me out later. But so small airways disease is common in RA. It's actually the most frequent connective tissue disease to call small airway disease. It's kind of a bucket term that loops in bronchiolitis obliterans, which is also called obliterative bronchiolitis or constrictive bronchiolitis, as well as follicular bronchiolitis. There's a couple path slides here that I think are helpful to understand. So this picture here is constrictive bronchiolitis. You have the airway in the middle here, and this goop here is fibrosis. And over time, this can progress to this photo where this was the airway, and all of this stuff is just fibrosis. So you can see how that is not good. You know, the airways are blocked off completely with fibrosis, and that's probably irreversible. Whereas the bottom path slide, this is your airway here, and you see all these blue things, which are lymphocytes, and these aggregates here. This is the bronchus-associated lymphoid tissue. So a lot of inflammation that actually narrows the airways there. And so you could theorize, at least if this are lymphocytes and it's active inflammation, this could respond better to steroids or immunosuppressants, and it does. Another interesting thing, small airways disease, the only risk factor that was identified in the literature was a heterozygous mutation in the CF gene. So it's kind of similar to bronchiectasis. So something is probably going on. Now you have two airways disease that are linked to a single mutation there. And if you scan all these people with RA, you might see it in up to 15% of people. That does not necessarily, they'll be clinically symptomatic, but you'll see bronchial wall thickening, maybe a mosaic pattern, maybe some air trapping if you do inspiratory and expiratory, or some ground glass nodules. And these biopsies can show constrictive bronchiolitis, follicular, or both. It's not like it goes from follicular to constrictive or constrictive to follicular. There's no real one goes to the other. These may be separate. They may be present at the same time. We don't really know. If this happens, you can try inhaled bronchodilators and glucocorticoids. It's not a guarantee that these are going to work. Constrictive bronchiolitis related to rheumatologic diseases, as well as lung and bone marrow transplants, can be responsive to immunosuppressants. So giving these people steroids could be helpful. There's not an established role for DMARDs and steroid sparing agents, but there was a single case report of someone who failed steroid therapy, who received methotrexate and etanercept, who had improvement. And etanercept's a TNF alpha inhibitor. So in theory, it could have worsened his fibrosis. It didn't in this single patient. Follicular bronchiolitis, like we said earlier, is actually more responsive to steroids. So hopefully they will improve. And what Dr. Abu-Saif told me is that a lot of times these people don't get lung biopsies. So you'll call them small airways disease. And if they respond to steroids, you'll say, okay, this is probably follicular bronchiolitis because it got better. There is some role in macrolides, not an established evidence-based role. There is for diffuse panbronchiolitis, but there's these couple of case series, one in 96 that showed that 11 out of 15, not 11%, 11 out of 15 patients had improved clinical symptoms on chronic erythromycin, and a Mayo case series that said these people had stabilized lung function, for whatever that's worth. I don't know if that meant clinically improved or just their lung function stabilized. All right, so we're filling up the slide. We're getting closer to done. We got ILD, pleural disease, large and small airway obstruction, as well as a laryngeal obstruction. So what's next? We're going to talk about some of the drugs. So apparently back in the day, we used to give these people gold, which is crazy to me. And I'll talk about that more later, more out of curiosity. But pretty much all of the drugs that were used previously, so penicillamine and gold, have already been closely associated with everything we've talked about and more as far as complications. Luckily, those aren't used as much, but you can see methotrexate doesn't have much more favorable of a side effect profile of possibilities. So pleural disease, bronchospasm, lung fibrosis, non-cardiogenic pulmonary edema. The other one that's commonly still used is sulfasalazine, which is linked to small airway disease, as well as a drug-induced lupus, which can make things more complex. So when it comes to these, it's important, when did this drug start? Did their symptoms worsen after it? Did their imaging or PFT data worsen after this? And if you get to a point of, I don't know, you can always trial them off it. There are other drugs you can probably use. And then this is your random fact of the day. Ridaru is oral gold that you can still buy apparently. You can find it on GoodRx for $700 for 30 pills, which is about 90 milligrams of gold, which is actually only about $55 worth of gold. So they're really marking up the price there. But you could get injections too previously, and you would inject about $25 equivalent worth of gold into your body twice monthly, which seems pretty funny to think about money being injected into you. No, into the, it was like a IM injection, like yeah, you go into the buttock or into the arm, just like you were getting a flu shot. Yeah. You can still buy it, apparently. I don't know. All right, so drug-induced lung toxicity is on there too. Rheumatoid nodules. Okay, so these are adding more confusion into the world of lung nodules. As far as connective tissue diseases goes, this is the only one that could cause a nodule. Lupus won't do this, Sjogren's won't do this, systemic sclerosis won't do this. Similar as before, oftentimes these people have long-standing joint disease. They often have subcutaneous nodules in their skin as well. And these are, cited to be extremely rare. Less than 1% of people radiographically have it, more so on autopsy. And the chance of you finding on the X-ray is so rare, 0.04%. But the size of this can be up to 7 centimeters in some patients. So it's very large. If you're going to try to differentiate this from malignancy, there shouldn't be any speculation. And if you were to biopsy it, there should be vasculitis on the biopsy. So that might point you more towards, if they have RA and there's vasculitis on their biopsy, that it could be an RA nodule. But to make things even more complex, some of these can be positive on PET scans and have SUVs up to 4.4, which you could definitely say if someone's got RA and a smoking history and this nodule that's 2 centimeters and it's PET avid, it's kind of hard to ignore. So it can definitely be confusing. RA, PH, good thing Dr. Kelly left because I really put this in at the end and didn't give it any love. So you can have group 1 PAH that's thought to be from a vasculitis, or you can have a group 3 from progressive RA-ILD. You treat this just like any other cause of group 1 or group 3. That's why it really didn't get any love. If you want to get fancy with this, so systemic sclerosis has like the detect algorithm that's in there, right? Of if they have this spirometry data, they should get an echo. That doesn't exist for RA-PAH, but I mean, the idea is very similar. So I mean, that data was, if someone's DLCO is less than 60% with a relatively preserved FVC, they get an echo. And I'd be hard pressed for anyone seeing someone in the clinic to say, okay, they have a DLCO that's less than 60. I'm not going to order echo if they have normal lung parenchyma. That doesn't make sense to me. So it's probably going to happen anyway. And then they would just say, if the echo looks abnormal, get a right heart cath. So it's not like that's going to escape you most times, but there's no specific treatment related to the PAH that you wouldn't do otherwise. Risk stratification, functional status, all that stuff would be factored into it. All right, we're nearly filled. And we get into our even last slide, which is all just the garbage bucket of things that have been associated with it. So to make the rheumatoid nodules even more confusing, there's a higher incidence of lung cancer with patients with RA. Whether that's associated with their smoking history, I'm not sure. The inflammation gives them a higher risk of VTE. They're at a higher risk of infection, probably from the immunosuppressants that they're on. They can get a syndrome similar to ankylosing spondylitis with thoracic cage mobility issues. They can get vasculitis. They can have cervical spine instability, which might be relevant to someone in the ICU. Lots of things. So pretty much you could always be on your differential for anything pulmonary, because we have laryngeal involvement, large airway, small airway, parenchymal, nodular disease, pleural disease, vascular disease. That's pretty much all of the things that can happen with the pulmonary system. Okay, so we filled it all up, and then I have a lot of sources, and that's it. Anyone have any questions? Yeah, they shouldn't. So what I saw was that they don't really grow in size, and that they kind of stay the same over time. But then, I mean, they have to come from somewhere. So at some point they grew, but generally over time they don't get much larger. There's at least one little case report was saying. Mm-hmm.
It's not clinically significant, and it's a, you know, you just like glance over it, like, oh, no significant change.
Yeah.
It does matter. Like,
yeah, and we didn't talk about it, but the pirfenidone case report, they used that as that was their primary endpoint, was a 10% decrease in FVC, and that if they could reach, you know, preventing that could be as a surrogate of improved mortality. And you can see it does slow the decline. So it's interesting.